Hello, I'm Kathy Insel, and I want to welcome you to our kickoff of our lecture series for Innovations in Healthy Aging. And we are very fortunate to have Dr. Karp, who will be speaking on responding to the tragedy of social isolation and loneliness in late life, keeping older adults connected. So I wanted to start off by giving you a little bit of background on the Innovations in Healthy Aging Strategic Initiative that we've begun here at the University of Arizona with a very focused energy on aging and how the university can share with its expertise your expertise together, and we can mutually move forward with our increasing aging population. So I wanted to give you a little bit of background. I want to thank Anissa Westcott and Denitza Garcia for preparing the slides that I'll be showing you. Thank you very much. They're a very important part of this Innovations in Healthy Aging program. So to begin with, some fast facts. The 65 and older population has been the fastest growing demographic since 2010. It's increased 34.2% nationally and 48.4% in Arizona. The surge in our number of Americans aged 65 and older this decade has outpaced the growth of the working age population, which is an important component of why we feel that this is a strategic opportunity for us. There are more than 1.3 million people in Arizona who are 65 and older, which is about 17.3% of the state's population, which is larger than other states in our country. And here you can see the fast growing pace of our older adult population. For Arizona, again, it's our 65 and older age group was the fastest growing since 2010, increasing 34.2% nationally. You can see the website cited there to validate these particular statistics. So our primary aim for this strategic initiative is to influence the critical factors that affect the health of an aging population. Our goals for this initiative are to create an age-friendly university, and we want to have your input to have better understanding of what that involves, what that requires. We also set out to partner with developers of senior living communities and aging industry experts to reimagine senior living. We are trying to expand our capacity in research and discovery with a focus on aging and increase the workforce available to meet both the opportunities and challenges of our aging population. So to do this, to build an age-friendly university, we are working toward outreach and engagement, research, creating a physical environment that is conducive for older adults to join into university activities, and providing services and resources. So you will see, and I want you to take a look at these next few slides are just to show you what the website looks like. We created an Innovations in Healthy Aging. The website, it will be shown again and again, but it's basically www. Actually, is it http://healthyaging.arizona.edu. And we're working on some other extensions as well. But I encourage you to go in and explore the website. There's this part, which is part of the Building an Age-Friendly University Innovations in Healthy Aging series lecture. There's Aging and the Arts, which we are working collaboratively with the College of Fine Arts and others on campus to promote aging and the arts and provide events. We also wanted to work with older adult communities, integrated senior living communities. This is a graphic that demonstrates the input that we have had in trying to create a sort of visual for how we see the partnership in relationship to assessing and building resilience with both cognitive, spiritual, social, emotional, and physical aspects, and also leveraging technology, using technology to promote health and wellness, and opportunities to monitor health. And the built environment, we're very fortunate to have a College of Architecture, Planning and Landscape Architecture at the University of Arizona, and they inform us greatly on building performance systems, architectural elements, and something I learned through this initiative, biophilic elements. Biophilic, by the way, means bringing the outdoors in, which is one of my favorites. Another thing that you'll find on the, and I apologize, that I've got to go back and capture, because that one, I was just trying to move your pictures around since I have just one screen in front of me right now. Another thing that you'll find is the research that we're trying to do. We are funding aging related research with seed funding. Again, go in here and look, because there are two things that we're trying to accomplish. We're trying to provide opportunities for you to participate in ongoing aging related research studies, as well as fund our junior investigators and other investigators who are moving into the aging field, so that they can go on and apply for and be successful at obtaining external grants. We also have focused on education as both a lifelong learning activity, so keeping your brain active and engaged, which is an important part of healthy aging. And take a look at this part of the website as well. And education includes also those academic and professional education experiences that our own students, or that students who might be attracted to this university because we have a focus on aging, can take advantage of. There are graduate and undergraduate courses, including non-credit classes. There are certificate programs that are available, so I encourage you to look at that section of the website. And there's also, more of the formal, both health-related, business-related, Eller College, and Law, College of Law. They have a program on aging and law for the non-lawyers. There are abundant opportunities in education at the University of Arizona, and I'd like you to be informed of them. So this is the website. It is https://. And now I want to take the opportunity to introduce our speaker, which is what you're here. So I definitely, I am aware of that. And I am very grateful to him for being willing to kick off our lecture series. So Dr. Karp is the department chair and professor of psychiatry at the College of Medicine, University of Arizona, where he also serves as both clinical service chief for both behavioral medicine and medical director for the behavioral health technology at Banner University Medical Center and Group in Tucson. He is an expert in the fields of geropsychology, or psychiatry, depression treatment, and suicide prevention. Dr. Karp, thank you very much.
Thank you, Kathy. Let me get my slides up. And is this showing okay? Good. All right. Well, we will get started. I'm really pleased to be here and want to thank Kathy and her team for inviting me to come and spend some time with you all this afternoon. I'll be talking about social isolation and loneliness in older adults, challenges that have become more attention has been paid to over the past couple of years given the pandemic. My disclosure slide. And this is what I'd like to talk with you all about today. This is the agenda. I'd like to share with you my approach to thinking about clinical research and how I prioritize clinical programming. Really, the way that I do that is to describe the problem. And to do that, we need to have some shared definitions so that we are using a common language. I want to talk about the epidemiology of social isolation and loneliness and the scope of the problem, and then also talk about the health impact, because while the distress, the emotional and cognitive distress of these conditions are certainly worth treating and preventing, we're also interested on their effects on health. We're going to talk a very brief bit about measuring the problem and then treating the problem. So as we get started, we need to make sure that we're using a common language, and we'll start by talking about some connection concepts, because social isolation and loneliness are distinct. But let's start with this broad umbrella term of social connection, which is really an overarching term, and it encompasses these other commonly used terms that we've been hearing so much about the past couple of years that describe the structural, so how things are formed and organized, the functional, what actually happens, and the quality, are they beneficial or detrimental for human relationships and well-being. The two other concepts that I want us to have a common or shared language about is social isolation and loneliness. So social isolation can be measured, and it's the objective lack or limited extent of social contacts with others. For example, marital status, living alone or with others, or engagement and contributions to networks and community organizations. And loneliness is the perception of social isolation or the subjective feeling of being alone in the world. Well, I wanted to really provide some more context for why this is so important. And this is a very interesting framework for public health action that Tom Frieden published, 12 or 13 years ago. It's the 5-tier pyramid that best describes the impact of different types of public health interventions, and it provides a framework to improve health. So at the base of the pyramid, this indicates interventions with potentially the greatest impact, and their efforts to address socioeconomic determinants of health. In ascending order are interventions that can change the context to make individuals' default decisions healthy, clinical interventions that require limited contact but confer long-term protection, ongoing direct clinical care, and health education and counseling. But I would say that interventions which focus on these lower levels of the pyramid tend to be more effective and have a bigger population effect because they reach a broader segment of society. And I would say that loneliness and social isolation are at the bottom of this pyramid. We call these socioeconomic factors social determinants of health. It's the non-medical factors that influence health outcomes. And in general, these social determinants of health account for about 40% of health outcomes. The different buckets of social determinants of health that we pay attention to are education access and quality, healthcare access and quality, neighborhood and the built environment, social and community context, and economic stability. And you all can consider how each of these buckets that contribute to the social determinants of health can interact with social isolation and loneliness. Well, let's move on and talk about the scope of the problem of social isolation and loneliness in late life. And this is a large study that was published in 2020 from the National Health and Aging Trends Study. This was pre-COVID, and it was a very large survey of community residing adults 65 and older. And what was observed is that the majority of older adults identify as socially connected, but about 24%, or 7.7 million of these participants in the project felt that they were socially isolated. And of these, about 1.3 million were severely socially isolated. I think this reflects a lot of changes that have happened in society and culture over the past 30 to 40 years. And I'm wondering if you have heard of this book called Bowling Alone. And if not, I would encourage you to take a look at it. It's a really interesting explanation of and description of why there have been declines in all forms of in-person intercourse and discourse over the past quarter century. So Putnam draws on evidence from about 500,000 interviews to show that we sign fewer petitions, we belong to fewer organizations that meet in person, we know our neighbors less, we meet with friends less frequently, and we even socialize with our families less often. What's an interesting observation is that we are even bowling alone. So there's evidence that more Americans than ever are bowling, but they are not bowling in leagues. And it's an interesting description of how changes in work, family structure, age, suburban life, television, computers, and I would say very importantly, women's roles have contributed to this decline. And let's talk about who is most socially isolated in late life. And so I would say the old, a badge of honor, those who are 85 and older, those who are unmarried, men, and those with low education or low income. And the loneliest subgroups in late life are people who have a small, non-diverse social network, who are physically isolated. So in particular, those who live in rural or frontier parts of the country, and LGBTQ+ and other marginalized groups. Well, I want to talk about some additional risk factors for social isolation and loneliness, and start by focusing on some cognitive biases that are related to depression and anxiety. Now, we know that depression and anxiety, I mean, it's pretty obvious, have a mutually reciprocal and exacerbating relationship with social isolation and loneliness. As a clinical psychiatrist and a clinical trialist, I try to understand mechanisms that may explain interactions between medical conditions and environmental contributors to these conditions. And one of these is that people who are depressed and anxious may experience their close relationships and social support as deficient or inadequate. However, this is not always the case. And even older adults who are depressed, who feel that they do have good social networks or really do believe that they are connected with people, still may experience higher rates of social isolation and loneliness. I think that loneliness in many of these cases reflect cognitive biases. And so when I'm working with patients, I considering whether they have a positive attentional bias or a negative attentional bias. And you can think of a positive attentional bias as those people who often see the glass half full. But depression in and of itself, with its brain changes and effects on emotions and cognition, force our attention for many people to be towards the negative. And those who are depressed or anxious often perceive their relationships as less rewarding. I think those personality traits that increase the risk of loneliness, especially among depressed and anxious older adults, are those who have low extroversion. So they are more introverts or they are avoidant of novel experiences, and those who have high levels of neuroticism. So worriers, people with problems with relationships, identity diffusion, and problems with anger often are those who, when they're depressed and anxious, perceive their relationships as less fulfilling and inadequate. I'd like to talk about some other additional age-related and modifiable risk factors for social isolation and loneliness. I'm sure that many of you have already considered many of these, but it's useful for us to go through them and think about them as we consider risk stratifying who may need a preventive intervention. So if we start at the left of this slide, certainly living alone for some older adults contributes to social isolation, which can lead to loneliness. In North America, we have this history or spirit of rugged individualism, and we have to make it on our own. And I think that can actually be a risk for some folks who may benefit from moving into more shared housing. Chronic and acute medical conditions, especially those which contribute to functional disability or mobility problems, can contribute to social isolation and loneliness, as can problems with access to transportation. Now, here's a very happy person who is in his car, but changes in access to independent driving certainly is a contributor. We know that unsupportive familial relationships, and here we have a very happy looking multi-generational family in the middle of the slide, can contribute to loneliness, as can excessive caregiver burden, as evidenced by this person holding the weight of his house on his shoulders. We know that grief and bereavement and a role transition from part of a married dyad to a single person is a risk for both social isolation and loneliness, as is moving. Finally, and this should not be perhaps such a small picture on this slide, are sensory deficits. So problems with hearing and problems with vision both contribute to isolation and possibly loneliness. Well, I would say that the problem has always been there, but COVID-19 has just forced us to pay closer attention. Well, some colleagues of mine, Ipsit Vahia, Dilip Jesti, and Chip Reynolds, prepared a viewpoint that was published in JAMA in December of 2020, so about 9 months into the pandemic, describing the mental health effects of COVID-19 on older adults. Now, I think that the mental health effects of the pandemic are going to continue to evolve over the next decade or so. And we need to remember we are still in a pandemic declared by the World Health Organization and the CDC. But there's some good news that my colleagues identified. Even early in the pandemic, multiple studies were indicating that older adults have been more resilient to the mental health effects of the pandemic than younger adults, probably because of learned experiences and developed resilience over the course of their lives. One of the other important observations is that wisdom, a beautiful benefit of aging, may be protective. So as I advance this slide and show you the measurable components of wisdom, I'd encourage you to consider your own lived experience and think about which of these accurately describe you. And are there certain elements here that you could work on to develop your own wiseness or wisdom? So empathy and compassion, emotional regulation, the ability to self-reflect, decisiveness while accepting uncertainty and diversity of perspectives, advising others, and increased spirituality, whether it's a closer connection to God or closer connection to community or nature. I think there's different ways of defining or experiencing spirituality. But many of these studies do show that greater wisdom is associated with greater feelings of being connected. And loneliness is linked with lower measures or perceptions of wisdom. Interestingly, perhaps the element of wisdom, empathy and compassion, is thought to be the most important aspect of wisdom that's related to lower levels of loneliness. Well, I'd like to move on and talk about social connectedness and health. And I probably should have made this image of the gentleman sitting alone in a cold and dreary outdoor cafe bigger, because there's evidence that social isolation and loneliness, the social determinant of health, may actually have a bigger impact on mortality and health outcomes than smoking or lack of physical activity and overeating leading to obesity. So let me share with you the results of a large study. This was a meta-analysis of 148 studies that included over 300,000 participants. And social connection was defined by marital status, the size of one's social network, and network participation. Were they passive participants or were they actively engaged and contributing to the success and function of their networks? And what was observed is that over a period of 7.5 years of follow-up, there was a 50% increased likelihood of survival, of staying alive for participants with stronger social relationships. Well, I'd like to share with you a case example that may help to drive home this link between cardiac disease and social connection. So this is a composite of several patients that I've taken care of over the past couple of years. But this is a 76-year-old man. He's been widowed for 10 years. He recently moved to a house in a gated community near Green Valley. and he wants to remain independent. He has one son in Chicago, no grandchildren, few local acquaintances, no local tangible or emotional supports. He communicates with his Army and college friends via email and occasional phone calls. He considers himself to be relatively healthy, but he has diabetes type 2 and arthritis, and he has macular degeneration and no longer drives. So he presents to the emergency department and is admitted for chest pain and left-sided weakness. And then over the next couple of months, he's readmitted twice to the hospital and goes to the emergency department 4 times. So let's unpack this a little more closely and think about some of these risk factors that we talked about a little earlier, and also think about yourself and other people who are in your social networks. So he's an older man. He's not the oldest old, but he is aged and he is a man. He is widowed. He recently moved. He has few local acquaintances, no local tangible or emotional supports. There is evidence that email and phone calls and Zoom is important for preventing social isolation and loneliness, but there's also increasing evidence that it's the face-to-face interactions, seeing people in person, that's important for preventing these negative well-being outcomes. He has diabetes type 2 and arthritis. So diabetes is a risk for cardiovascular disease, but he doesn't have hypertension. He doesn't have high cholesterol. He has macular degeneration and no longer drives, so some problems with transportation, getting around, and independence, and he has a sensory deficit. What I think is interesting here is he doesn't have tremendous risk factors for coronary artery disease or cardiovascular events, but there is evidence that social isolation increases the risk of stroke and heart attack by about 30%. And it also increases the risk of increased healthcare utilization. So he kept going to the emergency department. He was readmitted, which makes healthcare systems very interested in social isolation and loneliness, because it's the right thing to do to prevent it, to reduce the distress of people, but it also can save money. So let's continue with this case. 1 year later, during discussion with his primary care physician, he reveals symptoms of diminished interest and pleasure in watching tennis on TV, and he also has some depressed mood. He's lost 10 pounds over the last 6 weeks. He's having some difficulty falling asleep because he's worried, and he's waking up at 4 a.m. and he can't fall back asleep. He feels like he's more forgetful, and he wishes he would disappear or just not wake up in the morning. So I want to really reinforce that loneliness is a risk factor for suicidal ideation and behavior. And older adults who are socially disconnected and or are the victims of mistreatment, neglect, physical or emotional or sexual abuse are at greater risk for suicidal ideation. And in a large study of over 60,000 older adults, increased loneliness was one of the primary motivators for self-harm and suicidal behaviors. So this is a simplification of what I've described with this patient. We could think of it that he became socially isolated, he became lonely, he then maybe perceived that he had low social support, which contributed to depression. It's, of course, much more complicated than this, but it's useful to develop these sort of conceptual or clinical models because it provides opportunities for us to consider where can we intervene to make a difference. I hope I'm also teaching you all that depression is a risk for social isolation, it's a risk for loneliness, and it's a risk for low perceived social support. So preventing and treating depression may be one of the easiest patient-centered ways that we can break this cycle. I would imagine that concerns about cognitive decline and dementia is paramount for the participants in today's webinar. And there is evidence that increase in loneliness, decreased interaction with family and friends, and decreased participation in community groups are risk factors for cognitive decline and dementia. Now, there is evidence that these may be a two-way interaction, mutually exacerbating, but the evidence is stronger for these social determinants to be a predictor or perhaps a prodrome of cognitive decline and dementia. And certainly there's evidence that these social factors, these determinants of health, increase the risk of dementia by about 50%. Well, I think that this is a interesting but puzzling interaction. Why is it that loneliness and cognitive decline are related? What's the link here? Well, some of it just has to do with the fact that social interactions may enhance cognitive capacity through activation and maintenance of the efficiency of brain networks. So you think about getting together with others to see a movie, to play cards, to share a meal, to talk about a book. You are engaging your social cognition, memory, psychomotor speed. The very act of getting together requires planning. All of this is engaging and keeping brain networks active. But there's also evidence, and this is from a really elegant study in cognitively normal older adults with the average age of 76, about the same age as the fellow I just presented in that case. Increased perceptions of loneliness was associated with higher levels of brain amyloid and particular regional accumulation of tau protein, two of the biomarkers or substrates which accumulate in the brain and are thought to be involved with the development of Alzheimer's disease. So this really links loneliness with pathological changes of early Alzheimer's disease. And this was from my colleague Nancy Donovan at Harvard, who published this in JAMA Psychiatry. I think this picture really shows this well. The x-axis is amyloid burden in the brain. The y-axis is loneliness measured with the UCLA loneliness scale. And we're going to talk more about this because I promised we would talk about measurement. But positive correlation between these two. I think it's, but this project, Donovan's project, really was a replication of another study showing that feelings of loneliness, but not social isolation, predicted dementia onset. And this was published in 2014. I will read you the results. After adjusting for other risk factors, older people with feelings of loneliness were more likely to develop dementia with an odds ratio of 1.64 than people without such feelings. Social isolation was not associated with higher dementia risk. So it was this feeling of loneliness, but not being physically isolated. So let's talk about measuring social isolation and loneliness. We'll start with measuring social isolation. And as I go through this, think about yourself or people in your network or who you care about. So the Steptoe Social Isolation Index is a 5-item scale. There's 1 point for each item. These abbreviations here are face-to-face, phone, or email. So 1, unmarried or not cohabiting. 2, less than monthly contact with children by any of these methods. Less than monthly contact with other family. Less than monthly contact with friends. Or no participation in social clubs, resident groups, religious groups, or committees. And it's thought that for clinical use, really these are used in clinical research projects. I don't think it's used that much in clinical settings, but a score of greater than or equal to 2 is thought to suggest social isolation. We can also measure loneliness with the UCLA loneliness scale. It's a 3-item scale. Each of these items is scored with hardly ever, 1, some of the time 2, or often 3. And the questions are, how often do you feel you lack companionship? How often do you feel left out? Or how often do you feel isolated from others? I think that one question is really lacking, and it's often added on to this 3-item scale, but just to ask patients or others, do you feel lonely? So let's talk about some approaches to reduce loneliness in late life. Because there certainly are interventions, but first we need to identify the source because context is critical. We'll talk about 4 different dimensions or areas that we could focus on that may reduce social isolation and loneliness. And these are limited social skills, low social support, limited access to social interactions, and unhelpful thoughts about social situations. So this is a busy slide. I'm going to unpack it and make this a little easier for you all. But these are 4 interventions that we'll talk about. Purple are individual focused and red are systemic focused. So let's start with this first individual. So improve verbal and nonverbal communication and social skills, especially for people who have been loners throughout their life and now maybe they don't like it, or they've been socially awkward throughout their life. But there are online social skills training and practice. There are psychotherapies and coaching focused on social skills training that can be helpful for some of these people. This is a systemic approach, increasing social support, such as friendly visitors, virtual connections or groups, in-home support services, and meal delivery. Another systemic approach is increasing access to social interactions like telephone outreach, online chat, and we're going to talk about this in a little bit more depth in a minute, hearing aids and assistive devices, and social activities and transportation assistance. And the last one is another individual one. So changing unhelpful thoughts about social situations. And talked earlier about negative attentional bias, or the fact that some depressed and anxious people experience their social networks and social interactions and relationships as deficient or lacking. And interventions like cognitive behavioral therapy can be helpful in helping people identify automatic thoughts and consider alternative solutions or ways of experiencing their relationships with others. I want to take you to a website now that I think will be helpful, and I'm going to stop sharing, and then I'm going to reshare my screen. And there, I think you all can see this. So this is the AARP Foundation Connect to Affect. And it has a lot of really useful information about social isolation and getting connected, how to find help during the pandemic. But I'm going to take you through this assessment, and I would encourage people to come to this website after the webinar today. So we'll do this as a group. This is, are you affected by social isolation? Are you taking the survey for yourself, or are you taking it on behalf of someone else? I'll say for someone else. Do you participate in social activities or organized groups at least once a week, either virtually or in person? No. Do you see or talk to a family member or a friend at least once a week? No. Do you provide frequent care to someone who needs help with everyday tasks like grocery shopping, preparing meals, and getting to appointments? Yes. Do you ever have trouble finding transportation to get where you want to go? No. Is it difficult or impossible to leave your home without assistance? Yes. Do you avoid socializing because it's hard for you to understand conversations, especially when there's background noise? Yes. Do you often feel isolated from others? No. In the last 6 months, have you experienced a major loss or change, like moving or the death of a loved one? Yes. You're just one step away from getting help with social isolation. Get my results. And this suggests that I am at high risk of social isolation, and then it walks the participant through their answers and provides links to get ways to connect digitally. There's a caregiving website, transportation options, the AARP Hearing Center, searching for trusted virtual communities. And this is really interesting. There is online exercise groups, dance groups, book groups, a lot of opportunities for people to connect. So let me come back to my slides. Okay, so I'm getting near the end of my talk, but I also think that technology is a way to address and reduce social isolation and loneliness. And I wanted to highlight this company called Pix Health because they are Tucson-based. And I'm going to show you what the Pix Health app looks like, but I know that Banner University Health Plans, which is their Medicaid programs and Medicare Advantage and All-Tex program, and I think the dually covered Medicare and Medicaid has purchased this and is using it with their covered members. And Pix Health has said that health plan partners typically gain almost $3,000 in annual saving per user because many of these patients are high healthcare utilizers. So let's look at what Pix Health may look like. And this is really just a prototype or an example of lots of apps and social connection solutions that are becoming increasingly available that can be scaled up for population level rollout. So this is Janet. Janet suffers a stroke. She has an outpatient appointment, and then she also has an inpatient hospitalization. Well, we know that things are much more complicated than this because the majority of her health-related experiences happens outside of the traditional care setting. So she suffers a stroke, she has an outpatient appointment, but then she loses her job. She doesn't want to burden her friends. She starts to feel isolated. She feels depressed. She doesn't have enough money for food, and she stops taking her medication because she doesn't have food. This happens more often than we would like. So Pix Health collects meaningful information and it can deliver resources in real time. So the member is assessed every 2 weeks and social determinants of health are assessed monthly. So we already talked about the UCLA loneliness scale, depression and anxiety are measured, and then monthly the daily needs and safety are assessed. The Pix uses these cute emojis and little robots to get people engaged. And it says, every time you answer a question, my robot heart grows bigger and bigger. How often did you feel nervous in the last 30 days? And Janet would answer, and she says, a lot. And then this is an example of finding and offering resources. Thanks, Janet, for letting me know you need some help with food. And they link her with a way to get some nutrition. There's also in the moment intervening, self-management, CBT techniques, and a 24/7 nurse hotline. So the little robot asks, how are you feeling today? Please click on an emoji that best describes your state. And then this would lead them down an algorithm to help address depression or anxiety. This is a question, which area of your life is helping you feel most positive? And she clicks friends. And then if there was something urgent, it would ask Janet if she wanted to speak with a nurse while she was waiting, if she was having medical or safety concerns, and she just pushes this button and it would take her to the nurse hotline. I think that we need to be thinking more carefully and developing scalable interventions like this because as I hope I've convinced you today, the immensity of the problem is great, and I'm concerned that it will continue to develop given the ongoing challenges that we're experiencing in the world. So I want to end my talk with a summary that social isolation and loneliness contribute to suffering, mortality, and morbidity. Loneliness is different from depression, but depression is a risk. I think that loneliness may be a marker, if not a risk, of cognitive decline and dementia. The good news is that the majority of older adults are resilient, and wisdom and compassion are linked with less loneliness. And interventions to prevent and address loneliness are multifactorial. We need to be thinking both the patient level as well as the system level, and also considering digital interventions to help address the problem on a population level. I'll leave you with the statement that loneliness kills, interventions work, and if you or people you care about are experiencing social isolation or loneliness, get help. I want to thank you, our webinar participants, for joining us today. And I know that Kathy's going to talk about the upcoming roster of webinars that are scheduled, and I hope you'll continue to join. I want to thank the University of Arizona Innovations and Aging Programs, and a special thanks to Kathy Insel and her excellent team for inviting me to launch the webinar series this year. I think we're ready to open it up for questions. I'm hoping that Kathy Insel, who is a nurse and expert in gerontology, will join me and help me field any questions that we may receive from the audience. Thank you.
Okay, we have some questions in the chat, and I'm going to go ahead and get started. We have a question that says, question for Dr. Karp. The older of the old adults are not connected to the internet. Advanced age and some cognitive decline makes technology inaccessible. Suggesting to connect virtually might not be possible for lots of older adults. What are your suggestions then?
I agree that some older adults of the old are not as digitally literate as we need to get them to be. But you'd be surprised at how many people who are in their late 80s and 90s are connected. But when these interventions are developed, technological interventions, we need to make sure that they are age-friendly, very easy to use, with availability of tech support, because so many people just give up when they start with a new app or online programming because they're having problems with logging on. They forget their log-on credentials. This technical challenges and keeping people motivated with human soft touch support, I think, will help to solve some of these problems. But it's a great question, and we really need to be mindful of this challenge.
Thank you. Okay, next question. The difference between 65 and 90 are vast. In no other field do we assume such similarity in a 25-year range. What is being done to assess loneliness in various age groups?
Wow, that's a great question. I'm not sure that it's just age groups, but it is probably where people are living and what their risks are. So loneliness in somebody who is still living in the community, perhaps by themselves or with a limited social network, is different than somebody who's living in an assisted living facility, an independent living facility, or a skilled nursing facility. And I think attending to the special needs of folks living in each of these types of residences are really where we need to focus and stratify some of our interventions. And Kathy, I don't know if you have anything to add to that.
Well, I thought that the point you made about human factors and our paying close attention to the usability of technology and apps. I know some older adults may not have internet in their home, but they are now using smartphones. But they can only use these apps if they're able to manipulate them visually, with manual dexterity. So we have to be very careful about that particular aspect. And I was really happy you brought that up.
Thank you. Next question. All age groups, including older adults, are a niche marketing target. For older people, many supplements are advertised to improve memory and cognitive impairment or decline. Many are bogus, but perhaps some supplements are useful. Any thoughts?
I do not prescribe any supplements. If somebody has a low vitamin D, a low B12, or a low folate, all of which are linked with memory function as well as cardiovascular and bone health, I think that those should be supplemented. If people have a nutritional deficiency, then that needs to be addressed with their internist or their gastroenterologist. But I fear that people are spending hard-earned money on supplements without evidence to support their use. They may make people feel better because of a placebo effect. I'm all for the placebo effect, but I don't think it's fair that poor people can't afford to buy supplements. So I don't really promote them. Kathy, what are your thoughts?
Absolutely agree with you. I think it's important to have a healthy diet. And I think that we often, grab for things that might be gimmicky rather than just to live as fully and completely with a healthy diet. And I know that's more difficult, with aging as well. And also, I find the same thing is true in the context of some of the brain games that, people talk about in terms of technology, trying to improve cognitive function. The best thing to do is to get engaged with a lecture series like this and get to listen to Dr. Karp talk. So I think that's a really good start.
Thank you. Next question. Again, another one on technology. Older adults have trouble using new technology, especially if they already have some cognitive difficulties. Do you have any information on what age groups actually use the app you described? And I believe the name of that app was Pix Health. Is that correct?
That's right. So I don't have data on that. I agree with you wholeheartedly that this app continues to develop, as do others. And I don't think, well, I know that this is not specific for older adults. So like the example I gave you of Janet, that was that emoji or that cartoon was of a younger person. So we need more age specific or age sensitive interventions that are developed.
Thank you. Next question. This one's really a good one, I feel. Do you believe that all or most hospice patients experience some degree of social isolation and or loneliness as a result of their prognosis? And what is the very best intervention to alleviate this form of suffering at the end of life?
That's a very interesting question, but I can't generalize about all hospice patients, partly because talked about that people are very resilient, and people are in hospice having lived different lives, and a different path took them to where they are at the end of life. And many people who are in hospice are very wise, and they may have a lot of compassion, which can be protective against feeling lonely or socially isolated. I think that we need to attend to this, and it's part of good palliative care, but I'd hate to generalize.
Okay. Okay. How to help a family member who frequently feels uncomfortable driving, but is in denial about this transition. She's confused by the Lyft app and doesn't want to use it. She insists she can still drive, but often won't.
Hi. Okay. I think that if oh gosh, I don't know. Kathy, do you want to take this one? I don't want to get in trouble.
I know this is a classic concern, isn't it? And very difficult for family and for the person to negotiate these waters. Their new independence is often linked to driving. Living situations are sometimes dependent upon the car to move around. Apps like Lyft and Uber are not always that easy to negotiate either. So it's a dilemma for people. And I know that there is specific advice out there. I have read it. And I encourage you, I'd love to have a spotlight on this alone on the website. It would be great, because I encourage you to look for the evidence that there are certain signs that are important for us not to ignore. And if we can provide an alternative to the individual driving their own vehicle, I think that that's another important thing to do, or change the living context, which might be necessary in certain situations in order to eliminate this challenge. But there's no easy answer, and I think it's a case by case.
I think so too. In my own family, sometimes there's been challenges with ordering Ubers, just because of access to the internet outside of beyond Wi-Fi. And so just calling an adult child to order the Uber for the person who's no longer driving is also a pretty easy solution, and it's not a big deal, but something to consider.
Okay, we've got a lot more questions here, a lot of really great ones, and I'm sorry, I'm not sure we'll be able to get to all of them. Which would be better, to connect with young children in a school setting or to connect with even older people in a retirement setting? I'm not sure what the intent on that question is, but let me pass it on to you, Dr. Karp. Maybe you can address that.
Well, I think there's probably benefit to both, and it's energizing and exciting to be around young children and the promise of all that an early life portends. But there's also a lot of benefit of being around similar age people because of shared experiences and shared problems. So I don't know why it has to be an either or, and I would suggest doing both.
Thank you. Next question. We are still very worried about COVID-19. So my mom, who is only 90, only interacts with my brother, who is her caregiver. And my brother is very busy with all the work he has to do at home. So my mother feels very lonely. We call her every day, but she misses person-to-person interaction. What can we do?
Well, I wonder if if this 90-year-old woman maybe has some access to the internet and could seek some online connection with that AARP website that I shared. I mean, it's been a challenge during COVID with senior centers and senior activities being either shut down or gone to virtual, sort of like today's webinar series, I think in the past would have been in person. And a lot is lost by not getting together and schmoozing around the coffee table and talking after the lecture. But I'm hoping that things will continue to open up. It certainly is it's a different world that we live in, and it will continue to require vigilance to avoid getting ill. So I think that looking for these other ways to connect online, if she can do that, would be a great approach.
Thank you. Okay, having pets wasn't mentioned in your presentation. Does having pets affect the feelings of loneliness and social isolation?
It does for me. I think that pets are the best antidepressant, and I highly recommend getting a pet if you can have one and if you like animals.
Thank you. Okay. In the epidemiology aspect of the talk, what are strengths or barriers of differences in different loneliness scales? Does it allow us to compare between various populations?
I don't know the answer to that. I know that the UCLA loneliness scale is probably the most commonly used. I just showed you the brief 3-item measure. There's a much longer, more elaborate survey. I think it's 15 items, and it probably provides more granular information. And I would encourage you to Google it and take a look yourself. But I'm not such an expert in the measurement of loneliness to respond more than that. I don't know, Kathy, if you have any thoughts.
No, not about the measure, but I'm still stuck on the last question about pets. So I wanted to respond to that if it's okay. They did a study at one point in a nursing home and gave half of the people plants to take care of. And those people were happier and felt less lonely than people who didn't have the purpose. So I think purposeful lives are important. And I think pets also create that purposeful life for us. So I'm sorry to, digress to the former question, but I was really, and I totally agree. Pets, even fish, even something that needs you, that you are taking care of, I think is very, very helpful.
Thank you. And I think we only have about 1 more minute, so maybe one more quick question. Can you provide any information about social groups for retired individuals? You're muted.
So each community is different, and things are opening up. Every county has an area agency on aging, which keeps a list of these. Reaching out to faith-based organizations, even if it's not your faith, many of them also maintain lists and are glad to connect people. Local libraries also often maintain lists of organizations and meetings. And I see that Anissa just posted the pcoa.org website. Kathy, do you have anything to add to this?
No, I think it's a really good question. One of the ways in which you might be able to use the website for healthy aging, we hope that you can become engaged in the university, and those activities might actually lead to social relationships outside of the forum that you're in. So there's also Osher Lifelong Learning, which is OLLI. It's called OLLI for short. And it's another great place to interact with other people and to talk about meaningful things. So
I think I just want to respond to one question. One person wrote, I would like to remind everyone that one size does not fit all. Some of us are not lonely. I 100%. This is the minority. I mean, it can be a substantial minority, but most people are not. Most people are connected and don't perceive their relationships as lacking. So we're really focused on preventing this and helping those who need it.
Thank you. I think that's all we have time for today. I would like to draw everyone's attention to the link that I just posted, healthyaging.arizona.edu. We have a resources page that you might take a look at on our website that gives more information on resources that for older adults, if you're looking for things to do in relation to the U of A campus or services for older adults. Some places you can reach out to, like United Way of Tucson Elder Alliance, Tucson Medical Care for Seniors, etc. It's posted on that webpage.
I want to take this opportunity to thank Dr. Jordan Karp. I really believe you were the best kickoff speaker we could have had. And I also want to call attention to next month, we'll have Dr. Andy Weil talking about integrative health. So I'm hoping to see more of you this spring. These are going to be virtual lectures, but in the fall, we hope to meet in person and virtually if you're unable to meet in person. So, and thank you very much for coming. We really appreciate your engagement.
Thank you.